Hello, dear students. Today we'll be talking about the ureters and the course of ureters in the pelvis and in the abdomen. One of the most important questions in your exams has been asked many a times and would be asked henceforth as well. So the anatomy of the ureters in the pelvis is obviously very important. Not only this thing has been asked, but also the points of injury of the ureter and how can we prevent these injuries. That means applied anatomy basically has been asked. So since my anatomy series is going on, I have already taken a lot of lectures earlier on the various structures of the pelvis and the abdominal wall. I have now come down to last class was on bladder and bladder anatomy, obviously the bladder relationships and the applied anatomy. Today's class will be upon ureter, the course of ureter, the places that injury can happen and how to prevent that injury. So let's go forward and study more about ureter. So obviously the ureters, they are the urinary conduits which carry urine from kidneys to the bladder. They are hollow muscular tubes which are retroperitoneal in location, which is the reason why we as gynecologists we're not able to see the ureters, right there in front of us, and because of which there is a high chance of them being caught, being injured, being cauterized. So all these problems is there, and more with the advent of use of the monopolar cautery or cautery, let's say, the lateral spread of current is high, so because of which the chance of ureter injury, ureteric injury is even more. Especially the people who are doing laparoscopy, who've learned laparoscopy will know this fact for sure, that saline is the fluid which it is basically carrying. Actually it's more of the fluid is basically of the composition of salts. A lot of salts are there, salt and water, very good conductor of electricity, and because of which it catches the cautery, catches the current, it flows through it, and in the result it cauterizes it. As such also the spread of current in monopolar cautery, the lateral spread is very high, so because of which that can easily get injured, and the problem is definitely more. And why is it more? Because basically for cauterizing the uterine artery you need more current, because the walls are thick, you don't want any bleeding to happen, so you keep cauterizing more, and because of which the lateral spread is actually more, and ureters are right in proximity of that. For all those who want a better understanding of this topic, there's one more this lecture of mine, a very good video in which I've tried to describe to you, the anatomy between the ureters and the uterine artery, which has been pretty popular in the on the YouTube. Many of you must have already seen it, but I'm putting the link in the description. Go forward and watch that video as well to just open your horizons and make you understand the anatomy even further. Like I always say, when you have to be surgeons, you might as well be good ones. So which is why you understand every step of the way which I'm trying to tell you. So I'll be speaking less of the things which are there already in the book, which you can just read through. I'll try to explain you more through videos and through the pictures and through diagrams that I've tried to include, which will help you understand better when you're doing the surgery. So anyways, why? So they are basically retroperitoneal location, because the reason why we as gynecologists were not able to kind of locate them properly and to trace them properly. So let's go further and understand their anatomy. So they basically have three parts. One is the part which is there in the kidney itself. So it's one part is the ureter in the pelvis of the kidney. Then starts its abdominal part, which is the upper half is the abdominal part, is around 12.5 centimeters. So the total length being 25 centimeters. The upper half is 12.5 centimeters, which is there in the abdominal part. And then comes the lower half, which is the pelvic part, which is 12.5 centimeters itself. And the diameter is around 3 to 4 millimeters. And why do I say that? Why is it important? Because the stone, which is a ureteric stone or kidney stone, which is 5 millimeters in diameter, is got lesser chance to pass through. Okay, and a smaller stone, let's say 2.5 to even 3, usually passes through. So a stone of 5 to 6 millimeters diameter might have a chance of development of obstruction, of chance of development of backflow, reflux, hydroureter, hydronephrosis, and a smaller stone will be able to pass through. Still, this is not your decision. Always refer the patient to the concerned nephrologist or urologist. Now, only the pelvic part is discussed here in our scenario, because it's basically more important to the gynecologist. But nevertheless, I will be discussing a little bit about the abdominal part as well, because half information will not register in your mind. We'll trace it right from the kidney, right? So the pelvic ureter I'll show you a video after this, with the help of which you'll be able to understand the anatomy better. This is the one. So this is the pelvic part of the ureter. This is the pelvic part of the ureter. And here the course of the abdominal part it starts. When it starts over here, I'll just run through this video so that you're able to see this part is actually the abdominal part, right? And from here, when it starts coursing medially, here is the ischial spine. Can you see this? I'll just pause it a little. Here is actually the abdominal part. In the abdominal part, it's lying on the psoas major muscle. That's what it is expected of you when you're talking about, talking of the abdominal part of the ureter. This highlighted portion is the psoas muscle, and this is the iliacus muscle, this one, right? So iliopsoas, we many times we call it iliopsoas. It's basically the abdominal part. So over here, see, it's lying almost on the medial border of the psoas major muscle, right ahead of the psoas major muscle. And here, if you can see the ischial spine, it's here where it's going to move medially forwards. This is probably the pelvic part, and the part which we are going to speak, kind of more concerned with in being gynecologists. So here it bends a little towards forwards and medially at the level of ischial spine. Over here it's lying on the psoas major muscle, and its relationship over here is very, very important to the iliac artery. See over here, can you see this is the aorta? This is the right and left common iliac artery, and here is where it divides into external and internal iliac artery. So going closer, if you see, this is the common iliac artery, this is the external iliac, this is the internal iliac. At the level of the junction of these two ureter, and see over here somewhere, will be the uterine artery. It's a branch of internal iliac artery. I'll show that figure as well to you. So can you see this? That it's like at the level of sacroiliac joint over here is actually the division of the common iliac artery into external and internal iliac artery. And at the junction of this division, the ureter is kind of lying over it, definitely in relation with the medial border of the iliopsoas muscle, but also at the level of the division of common iliac into external and internal iliac. And now everything will be removed for you to understand better, and then it traverses even down and down until it reaches the iliac, this thing is the ischial spine, and then suddenly it turns forwards and medially. And this course I'll take up in the, so this is the 3D look. Have a look at that. It's going, this is, they're trying to show that here is the bladder and its relations. I had already mentioned in the last lecture of mine very beautifully. Again, taking a 3D image, and now we'll see the next diagram. In fact, this I'll take up first. So this is the division. Here's the common iliac artery, external and internal iliac artery, and it's lying right at the junction of this. After a while, this iliac artery, internal iliac artery, will give away the uterine artery branch, and then you'll see that uterine artery runs absolutely 90 degrees to the ureter, uh, actually over the ureter, and then this is called as water under the bridge. So over here, if you can see, you saw this. This is the ovarian fossa actually over here, and here you see this is the division. This is how it looks. This is the uterine artery, and this is the ureter. Can you see this? Over here, this is the ureter, and this at right angles is the uterine artery. That's the relationship of the uterine artery with ureter. But what you do is, while you're doing a hysterectomy, is that you push. You cut the broad ligament from behind and in front, and it goes lateral. So you can easily put a clamp over here. It's only when the clamp slips, and I've given you the answer. One of the answers of how can you damage the ureter, it's when you've not put a proper clamp on the uterine artery, or you've not taken proper sutures, or the suture goes lax, and when the it starts bleeding and it starts retracting laterally in order to attempt to clamp and control the bleeding, you inadvertently clamp the ureter. That's the reason why uterine artery pedicle is the most important pedicle in hysterectomy and should be taken very, very diligently. No rush, no heroics. Be very, very calm, cool, composed, and very, very diligent in taking uterine artery pedicle. So you saw that how it is, lying at 90 degrees to the uterine artery over here. And one more figure I'd like to show. This is what it looks like. Actually, why you can't see the ureters, because it's totally retroperitoneal. And if you can see the broad ligament, what happens over here? See, in resting state, we say the tube, it rests on the ureter. Okay, that's what we say in resting state. If you just put the uterus down, right now it's antiverted. Most probably uterine manipulator is inside and putting the uterus antiverting the uterus. But if in a resting state, usually these two, the tube rests on the ureter. And right now it's like kind of a little lifted above, and that's how you can see this is the course. See, this is the, if you can see, if you can appreciate, this is the common iliac artery, right? And over here is the junction. Here inside is going the internal iliac artery, and here the thicker one, this is actually the external iliac artery, somewhere right under this or close to this. So this is the ureter which is channeling over here. Once you cut this broad ligament, it's kind of laterally delineated. And this is the broad ligament actually with which they are in close connection with the ureter part. Okay. And when you delineate it laterally and then you put the clamp, then it's fine. Everything is okay. But what happens later on is also important. If it gets slipped away, the pedicle kind of slips. So this is the anatomy that I wanted you to know, because that's the part of pelvic anatomy we're going to be talking about. So only the pelvic part we're going to discuss. Although I've already discussed with you the abdominal part, nobody's going to ask you anything more than just the fact that it's lying over the psoas muscle. Let's take up this part first, the ureter. So it's anterior to the psoas muscle, right? It's also anterior to the genitofemoral nerve, which we couldn't see at that time, but in this picture you'll be able to see. I'll just increase, I'll try to zoom, but it's not clear anyways. So let's see. So over here, can you see this part is also lying above the genitofemoral nerve? So there's a nerve over here, which is the genitofemoralis. Anyways, it's anterior to that. Posterior to the ovarian vessels, because like I told you, ovarian vessels, they are supplying the ovary in the ovarian fossa, and because of that, it's like posterior to the ovarian vessels. Anterior to common iliac artery, we just saw. Turns medial distal spines, we just saw. Posterior to the uterine vessels, water under the bridge, I just told you. Lateral to the supravaginal region of the cervix. Now, that's also another very important part at which it can get injured. I'll be telling you that in shortly. So, it's like at the level of uterine artery, at the level of uterosacrals. Ureter is very, very close. Even at the time of vault, suturing, don't go to front and back. Be a little closer to the edges rather than going a little too deeper front or back. Back you can take liberty with, anterior you don't. You just can't. Not in hysterectomy, definitely. What about the constrictions of ureter? You've got three constrictions. One is the pelvic ureteric junction right there at the top over here. The other constriction is at the pelvic brim. What is the pelvic brim? Which is the pelvic brim? Okay, I'll tell you. I'll tell you. This is the pelvic brim. It's lying over here. There is a junction. There's a constriction over here as well. So you have a pelvic brim constriction. Then of course the uretrovesical junction. It has to be kind of, there has to be a little bit of constriction there. Otherwise, how will it enter the bladder? Again, I'm going back again to just finish off my lecture a little bit about the relationships. So, the pelvic ureter transverse the pelvis after crossing the bifurcation of common iliac arteries and just medial to the ovarian vessels and then fundibulopelvic ligament. Now, that's very, very important. See, over here, infundibulopelvic ligament is here, right? It's somewhere here. And it's like lying right around that place. So, that's another place where it can get injured. So, it's saying that it forms the posterior boundary of the ovarian fossa. We just saw that, and it's lying medial to the ovarian vessels and then the fundibulopelvic ligament. So it's another place where it can get injured. It descends in the pelvis, being attached to the peritoneum of the lateral pelvic wall in the broad leaf, in the posterior, I should say, in the leaf of broad ligament, the posterior one. And during this course, the ureter lies medial to the internal iliac branches, anterolateral to the uterosacral ligaments, anterolateral to the uterosacral ligaments, because it has to go anteriorly. It traverses the cardinal ligament through the ureteric tunnel, which is very, very important, around 1 to 2 centimeters lateral to cervix. Can you imagine that? That's exactly the place at which you put the clamp. But since you lateralize it, you push the bladder down. Please have a look at that video of mine. I've tried to explain it to you even better, how it gets pushed and how ureter automatically goes down and you get a safe zone to operate upon once you push the bladder down. So though it is 1 to 2 centimeters lateral to the cervix in the ureteric tunnel. Ureteric tunnel, it's very difficult. Even if you've traced the entire ureter till here, I'll show you once again. If you've traced the entire ureter, even if you open it up somewhere over here and you trace it till here, in ureteric tunnel, it's very difficult to trace because there's a whole, a bunch of uterosacral ligaments where, the ureter is like lying beneath it. And it's very difficult to trace it, especially if you do the surgery of cervical fibroid. It's very very important to trace the ureter till the ureteric tunnel and even beyond it, because when you go to the ureteric tunnel and you put your clamps, you should know that ureter is not been taken in that clamp because you're already pretty lateral as it's a cervical fibroid. Okay, going back. So at this point, it traverses the cardinal ligament through the ureteric tunnel. At this point, the uterine vessels also cross superiorly from lateral to medial side. I'll just show you through a beautiful diagram. It then runs anteromedially towards the bladder base. So it goes more antero and more medial to the bladder base. I told you in the last lecture how they enter the two ureteric orifices. Very close to the anterolateral side of the upper third of the vagina. Okay, so many times ureterovaginal fistula takes place. If the ureter accidentally gets caught and gets sutured with the vagina, the ureterovaginal fistula takes place, and it's very not very easy to kind of operate upon. Ultimately, it enters the bladder, travels obliquely for 1.5 centimeters, and then opens in the ureteric orifices at the trigone of the bladder, 2.5 centimeters away from the other ureter. So the distance between two ureters is not very much. It's just 2.5 centimeters, just this much, about an inch. Its lumen is narrower at the pelvic brim, near the uterine artery, and in the bladder part. I just told you the constrictions. Near the uterine artery, bladder part, pelvic brim. Okay, uterine artery also they've included, right? Now let's go forward to where we had spoken about. Let's talk about the histological structure briefly. From within outwards, ureteral mucosa is a transitional epithelium, like exactly the mucosa of the bladder. That was also transitional. This is also transitional. Here you have a middle layer of muscularis muscle, inner longitudinal, outer circular. Remember what was it was in case of bladder? Outer longitudinal, then inner circular, then inner longitudinal again. It's just the it's slightly similar to that. It's the outer layer, inner longitudinal layer. Okay, so you have inner longitudinal layer and outer you have circular layer of smooth muscle. The outer layer is connective tissue sheath of fascia and it's adherent to the peritoneum. What about the blood supply? It's very interesting blood supply. Why is it interesting? Is because every place which the ureter is traversing, it gets a blood supply from there. It comes from the kidney, so it gets renal artery. Goes to the ovarian fossa, it goes ovarian artery. It crosses the common iliac artery. Again, it crosses internal iliac artery. Uterine artery. Reaches the bladder, superior vesical artery. Simple as that. If you know the course of the ureter, you will know the blood supply. You don't have to think about it. What about the lymphatic drainage? Into the para-aortic, internal iliac, and external iliac lymph nodes along. That's exactly how it's going. So it was coming right from aorta, para-aortic, internal iliac because it was traversing that, external iliac again because it was traversing that. Ovarian and vesical plexus are responsible for supplying sympathetic and parasympathetic nerves. That's all you need to know. Nobody asks about ureteric innervation. They ask about bladder. A lot about bladder. Do not ask so much about ureteric innervation. And it develops from the ureteric bud from the mesonephric duct. You should know that. Bladder was developed from urogenital sinus. Now, let's go forward. I think I've done this. I have now. Let's talk about the interesting topic that's asked in many times in examination. And with this, we'll finish with urethra also today. So, ureteric injuries. See, the mechanism of the ureteric injuries taking place is different, and how to manage ureteric injuries is a totally different chapter. To manage ureteric injuries, that Bowery flap and sauce hitch and all that, these operations are included. And of course, it's got all different kinds at which place the ureter has got damaged, how badly it has got damaged, and accordingly the management is given. It was even asked as one of the questions in your DNB examination, and the answers are already included in my solved answer bank. Go and check it out from there. And right now, just because this topic is going on, let's talk about the ureteric injuries. First of all, the kind of ureteric injuries. See, even if you close your eyes and if I ask you what kind of ureteric injuries can take place, you'll answer, I think 100% answer you can give. Either the ureter can get ligated, or it can get caught, in the clamp. See, let's start from the fact that it can get caught in the clamp. So putting a clamp first, it can get crushed. It was not just caught, you didn't realize it, you crushed it also. So it can get crushed with the clamp. It can get ligated, you know. You did not hold it with the clamp, but when you were taking a stitch, you went a little too deep and automatically the ureter came inside. Okay, mind you, once you've taken the stitch, it's very difficult to understand that you've already taken the ureter. Otherwise, you until unless you have that eye for suspicion. So it can get ligated. That is a third way. Most important, it can get cauterized. You were cauterizing somewhere close, and there was a lateral spread of current, and the ureter also gets injured. So let's see. Ligation, and now I'll ask you the site at which these things can take place. Okay. So one is the kind of injury, one is where this injury can take place. So step of the surgery when the injury can take place. So at pelvic brim, when you're ligating the IP ligament, would you like to see the figure again? This place, when you are trying to ligate the IP ligament, the ureter can get caught. Okay, you can go too lateral, become a little over judicious, you can easily catch it. Okay, so at that point in time, you can just catch the ureter. At the time of uterine vessels, come on, that's no brainer. I've been shouting my lungs out to you that at the time of ureteric, vessels, at the time of uterine vessels, ureter injury is very, very common, right? Because it's crossing right below it. Let's see that figure as well here. So while you're ligating the uterine artery, a little overzealous attempt, and you'll catch the ureter. Ligation of the uterosacral ligaments, another very important part. Let's see where I can do justice to it. See over here. This is where these are the uterosacrals, right? Over here, right there is ureter. This is the ureter. Okay, this is the one. This is the place which ureter is going, traversing, and it go here. So again, very important place where the ureter can get injured. And finally, pelvic lymph node dissection. You go lateral over the common iliac vessels to get some lymph nodes, and you have already injured the ureter. So I think we have spoken about the ureter in depth. Let's just read through this slide. Being in close proximity to many structures, ureter can be injured. Needs to be identified during surgeries because by its white glistening. Now, let me tell you, done so many surgeries, it's not that easy to delineate ureter. White glistening appearance. Even the arteries have that white glistening appearance. Don't think that the arteries inside will look red and veins look blue and ureter will look glistening white. It's not like that. I'm sure all of you have seen these surgeries. All of you know how it looks like. So it's not that simple. It looks white glistening, everything looks there. Underneath the peritoneum, vertical blood vessels on it and peristaltic movement. So the only thing with which you can find out ureter is through this peristaltic movement. You just give it a touch 2-3 times and it shows a peristaltic wave. So the injuries, like I told you, can be crush injuries, transection injuries, ligation, and kinking. Yes, kinking also can take place. All right, ischemic injuries, like you did not take it completely. One of the milder injuries is kinking. You did not take it, but you took something above it, and the ureter hitched up like this, got kinked. Just think about a pipe, a pipe, the ones that you use to water the garden with. That pipe, what all can happen? Sometimes you've been doing something else and it gets, because there's a lot of fascia inside the peritoneum, right? So it just gets pulled away and gets kinked in the process. So up to 50% injuries are not diagnosed intraoperatively. That's even worse. Okay. So what are the common sites of injuries we've talked about? I don't think we need to speak it again. And now let me go to and finish off with female urethra. Though urethra, nobody really asked, but since it's a discussion, let me just finish it off. So urethra is short, 4 centimeters in length, 6 millimeters in diameter. Lumen begins at the internal urethral orifice and within the bladder and courses through the bladder base for less than a centimeter. The region of the bladder where the urethral lumen traverses the bladder is called as the bladder neck. It runs downwards, forwards, embedded in the anterior wall of vagina. Now that's very important. When you're taking, I remember me telling you in vaginal hysterectomy workshop that when you're doing this vaginal hysterectomy, the place at which you hold the Alice forceps is at least 3 centimeters away from the urethral meatus. The reason being that urethra and vagina, they're so close in approximation that if you try doing anything, you'll end up an injury to the urethra. So do not try to raise a flap of vaginal wall from close to urethral meatus at all. At all right. So that's the advantage. It then runs downwards, forwards, embedded in the anterior vaginal wall, being behind the pubic symphysis. Pierces the deep perineal pouch. Yeah, it's one of the important structures of the deep perineal pouch. The sphincter urethrae is very, very important muscle of the deep perineal pouch. Apart from that sphincter urethra, you have deep perineum. Okay, one was superficial perineal, superficial transverse perineum, and one is deep transverse perineum. So deep transverse perineum muscles are the other muscles in the deep pouch. And of course, in the vestibule between the labia minora, anterior to the vaginal opening, about 2.5 centimeters behind the glans of clitoris. So it's very close in contact with the glans clitoris. It's inside the vestibule between the two labia minora and ahead of or anterior to the vaginal opening. It's anterior to the symphysis pubis with loose areolar tissue, and so it's related anteriorly. Anteriorly, you have symphysis pubis. Posteriorly, it's related to the anterior vaginal wall. Skinny is tubules. Laterally, it is related to the urogenital diaphragm, bulbospongiosus muscle, and the vestibular bulb. And you have very important two glands, the two paraurethral glands, the Skinny's glands, which open in the either side of urethra, two Skinny's glands, also the male counterpart of the prostrate gland. You have internal sphincters made up of decussating involuntary muscles. Uretrovesical junction helps in maintaining the continence, very, very important. External sphincters made of voluntary muscles. And they take origin from the inferior pubic rami, are present in the urogenital diaphragm, allows for the voluntary control of urine flow, which is again a very important thing. Radiology is not very important, guys. Since I'm already taking it, let me just finish it off. It's lined by transitional epithelium in the bladder neck. Okay, since it was close to the bladder mucosa, let's just assume that there's transitional epithelium in the bladder neck, and a pseudostratified columnar epithelium in the middle. When it goes outside, it's more of stratified squamous epithelium at the urethral meatus, towards the end. Very important thing now it's coming up. Urethral mucosa is estrogen sensitive, which is even bladder mucosa. Submucosa is definitely vascular and surrounded by a circular layer of skeletal muscle called the sphincter urethrae or the rhabdosphincter. You have junction of middle distal one third of urethra, two straps of skeletal muscle, proximal compressor urethra, distal ureterovaginal sphincter, they are present. These two muscles were called deep transverse muscles previously. Together, these three muscles, the sphincter urethrae, compressor urethra, and ureterovaginal sphincter, they form the striated urogenital sphincter complex or external urethral sphincter and provides a constant tone to provide emergency reflux activity in the distal half of urethra to maintain continence, which is very, very understandable. As far as the arterial supply is concerned, you think it yourself. You'll have the inferior vesicle, okay, vaginal because it's right there, internal pudendal because it supplies all of the perineum, and the venous drainage is through the internal pudendal veins, like it's there in case of all perineal structures. Nerve supply is innervated by vesicle plexus, pudendal nerve. Pudendal nerve, the main nerve supply of the perineum. And function, micturition, continence. So with this, guys, we finished today's lecture as well. I hope you've been enjoying these lectures. I have been enjoying because right from the perineum, lecture, which I've got a lot of, positive reviews on because it was not easy to understand the deep perineal pouch, the superficial perineal pouch. But that lecture, a lot of concepts have gotten clear. A few people. Not just that, things are getting, kind of imposed in your mind. And I do understand now the importance why you all were asking for anatomy lecture. I thought it's pretty straightforward and from the book. Why should I take a lecture on that? But now I understand what glitches were you facing. Our last lecture was on bladder and bladder anatomy relationships, and I hope that also did justice to your understanding of bladder and this one on ureter. So happy viewing, guys. Keep a track of all the lectures, keep viewing. Anatomy series is now about to get over, and hopefully now in my live classes I'll be bringing about embryology and its understanding. So it's another very dreadful topic. I have never been good in embryology myself when I was your age, student life, but now I do understand how complex and how important embryology is. So let's take up a few lectures on that. So I see you in my next classes pretty soon. Let's see, finishing off with anatomy, then we'll take up with the other. This Sunday, I'll just announce the class today itself. It's going to be on abdominal hysterectomy, a lecture from my own OT in which I've tried to show you how to repair cystocele abdominally. So just watch out the live class on Sunday at 8 p.m. on my Telegram channel. Till then, bye-bye.